Thanks, Phil. All right, so this one will be uploaded to the YouTube channel sometime this week. Dr. Lemos has agreed to have that done. So I just want to introduce our speaker today. So today we have Dr. Diego Lemos, who's an associate professor of radiology with a secondary appointment in orthopedic surgery at the University of Vermont Medical Center, where he served as the residency program director in the past. He currently is the MSK Fellowship Program Director, the MSK Section Chief, and the Clinical Director of MRI. Diego has been given numerous awards, including 13 from the RSNA for his work in education and research. He has authored 3 book chapters, 15 articles, and 53 educational exhibits, with several more anticipated this year. He's an active social media radiology educator. If you are not currently following him on Twitter, I would encourage you to do so if you have a Twitter account, as his content is excellent. Pre-COVID, when people still were invited to visit and do talks, he was a frequent visiting lecturer at regional, national, and international events. We're delighted to have Diego present for our e-lecture series today. And with that, I'll turn it over to Diego.
All right, can you guys hear me?
Yes.
Okay, so let me share the screen. Can you guys see that?
Yep.
Okay, so thank you, Adam, for your introduction. I want to thank you for the invite, as well as the remaining of the group and at Emory for this great series. I think it's an awesome initiative, particularly during these times, and I have heard nothing but pros and great comments so far with all the lectures that have been given. So Adam asked me to, well, good morning, I suppose, to some people here in the States, good afternoon and good night in other parts of the world. And Dr. Singer asked me to talk about the MRI imaging of acetabular labral tears this morning for 55 minutes or so. So it is a lecture that it was born from the concept of collagen architectural framework of the labrum in the hip. And this is a concept that Dr. Resnick, I did my training at UCSD with Dr. Resnick and Dr. Pathria and Dr. Chung. This was something that it was really emphasized during our training over there. So I don't have any disclaimers, any financial interest for this activity. The objectives for the lecture is to review the gross macroscopic and microscopic anatomy of the acetabular labrum. We're going to try to show the similarities between the collagen architecture of the labrum in the hip versus that one of the labrum in the shoulder and the meniscus in the knee. And we're going to show as well the pattern of microvascularity of the acetabular labrum, which again is very similar to the microvascularity of the meniscus and the labrum in the shoulder. Because of these similarities between the collagen architecture and the pattern of microvascularization, we will understand why the tears in the labrum of the hip occur the way they do, and why they look the way they do, and why we use a similar terminology to the one that we use in the shoulder and in the knee. We're going to discuss something about the nomenclature, and then I'm going to show you the MRI imaging appearance of different kind of labral tears and detachments, with emphasis on this terminology. I wasn't going to discuss the imaging of the post-operative labrum in the hip, but actually last week, one of my fellows told me that I should include some cases. So I put early this morning, actually, a few cases just to show you the post-operative imaging of the labrum. So just a brief introduction. The acetabular labrum, as we know, is a rim of fibrocollagenous and dense connective tissue, and it's very similar macroscopically to the labrum in the shoulder and the knee. We will see that it has 3 main layers on histology, and again, this is very reminiscent of this architecture of the labrum in the shoulder and the meniscus. We're going to discuss some of the patterns of failure and the direction of the tears, whether they are parallel or perpendicular to the circumferential collagen bundles. And we're going to also talk about the vascularity. Now, if you look at the hip on FAST, when you disarticulate the joint and you remove the femoral head, you can see that the acetabulum has this semilunar morphology, or like an inverse horseshoe shaped structure. Now, what really completes the so-called circle concept inferiorly is the inferior transverse acetabular ligament, which connects the anterior and the posterior horns. The functions of the labrum, of the acetabular labrum, is similar to the glenoid labrum and the meniscus. They do act as shock absorbers and joint lubricators, and they help to distribute equally the pressure across the joint. The geometry of the acetabular fossa is certainly different to the glenoid fossa in the way that the acetabulum is deeper. But the labrum, the acetabular labrum, does increase a little bit the depth of the acetabulum, as well as the contact area for the femoral head, approximately 21% increase in the depth, and about 28-30% increase in the contact area. And lastly, we can say that the labrum also provides a hermetic seal for the pressure in the joint, which is negative, and allows the freely flowing of synovial fluid and the lubrication of the articulation on both surfaces. This is a diagram from one of Mark Safran's articles on the clinical sports medicine that I like, because it shows that the acetabulum, there is a bony projection that actually protrudes into the substance of the acetabular labrum at different degrees. And in this diagram, we can appreciate that the labrum has three surfaces, okay? It has an internal articular surface, which is facing the femoroacetabular joint. And then it has a capsular or external surface, which is here against the capsule. So we ended up having a little perilabral recess here. And then you have the base of the acetabular labrum. You have this transitional zone between the hyaline cartilage and the fibrocartilage of the labrum, and we will talk a little bit more about that later on. Morphology-wise, the labrum does have variability, as does the labrum in the shoulder. Sometimes can be, the majority of times it's triangular, but sometimes can be more rounded. Occasionally can be absent. Sometimes can be quite bulbous, and we will review some of those appearances. The triangular morphology is about 70 to 80% of the cases, but like I mentioned before, about 50% can be rounded, and sometimes can be a little bit irregular on its very edge, and that can pose a diagnostic problem. Occasionally, as I mentioned, it can be absent. Actually, Dr. Sersel once showed me a very nice case of an absent acetabular labrum, and it was kind of reminiscent to the Buford complex in the shoulder, because the labrum was absent and the iliofemoral ligament was quite thick, like similar to the thickening of the MGA shell that you can see in the shoulder when you have a Buford. Histologically, early on fetal development, this is a photomicrograph from an article about the embryology of the acetabular labral condyle complex. Here's the reference from JBJS from 2008, if you're interested on further reading. And this is a fetal hip at term. So what it is, to orient you, is here's the acetabulum, and here is the humeral head. The femoral head, excuse me. Here is anterior, and here is posterior. So this already shows you morphological differences between the anterior and the posterior labrum. In the hip anteriorly, you can have this interarticular projection, and you can have a variable cleft that you don't see posteriorly. Similarly, the orientation of the collagen fibers anteriorly is different than the orientation posteriorly. Anteriorly, the collagen fibers are parallel to the chondrolabral junction, where if you see here, posteriorly, the orientation of the collagen fibers is more perpendicular to the chondrolabral junction. Here, another couple of photomicrographs to show you. This is a baby, these are fetuses at term. And here is anterior, and here is posterior. This is the acetabulum, here is the labrum, and this is the transitional zone, the histological transitional zone. So you can see anteriorly how this transition zone is very well delineated and abrupt, while posteriorly, the change from the hyaline cartilage to the fibrocartilage is more gradual. That differentiation is not as abrupt and well delineated as it is anteriorly. So some people believe that the fact that the orientation of the collagen fibers, the concentration of those fibers, the presence of a cleft, the graduality of the transitional zone versus the abrupt zone anteriorly is what predispose us to have the majority of our tears being located anteriorly rather than posteriorly. Now, we need to make a note that also some overuse injuries can predispose to particular location of acetabular labral tears, as well as some of the activities of daily living. For instance, it is well known that posterior and posterior superior labral tears are more frequent in Japan and in other East cultures when compared with Americans and Europeans. And that's probably related to the fact that they do a lot of more sitting and squatting in some of those cultures when compared to us. With regards to the microvascularity of the acetabular labrum, we do have a branch coming from the obturator artery, but the majority of the vascularity comes from the periphery and comes actually via the superior and inferior gluteal arteries. Okay, this is a picture from an article from Kelly and colleagues about the vascularity of the hip labrum. It was a cadaveric investigation when they injected, the India in here to show how the vascularity comes from mostly from the capsular side, as you can see here. And the vascularity is greater at the capsular portion of the attached osseous acetabulum for the labrum than from the inside. And that's very important because this actually corresponds to the peripheral third of the meniscus. So it's quite analogous to the red zone of the meniscus in the knee and the vascularized peripheral third of the glenoid labrum is the same for the acetabular labrum. So it does make a sense when you have a labral tear, if the tear is occurring more, towards the free edge or in the capsular side or more towards the periphery. Sometimes we cannot see describe that accurately on MR imaging, but when you can, I think it's very important information for the orthopedic surgeon to know where specifically this tear is located. This is a nice diagram from Dr. Sabral Betran from Dr. Stoller's book about the hip, showing you again the vascularity coming from the capsular side to the periphery of the labrum. And this anastomotic ring, this ring of fire, is formed pretty much by contributors from the superior and inferior gluteal arteries, plus the one from the obturator artery, and some of the radial branches of the periacetabular vascular ring that come also from the medial femoral circumflex artery. This is a nice dissection of another hip that it was disarticulated and the femoral head was removed. This is from one of Dr. Mark Safran's articles that I like for several reasons. There are several analogies here that I can make for the hip versus the shoulder. As you know, on the shoulder, we have the capsule and we have the glenohumeral ligaments, the three glenohumeral ligaments, well, maybe four, but the three main glenohumeral ligaments that reinforce the shoulder capsule. And between those ligaments, there are areas of weakening that are not reinforced, and those are the rotator interval and the axillary recess. Well, similarly, in the hip, you have the three main named ligaments, which are the iliofemoral ligament, which is, pretty strong, is the so-called wide ligament or ligament of Bigelow. You have the pivofemoral ligament, and then you have the ischiofemoral ligament more posteriorly. And those ligaments do have specific footprints in the acetabular rim that if we use the clock face, they have been clearly delineated. And between those footprints, you have areas of inherent capsular weakening. And it is through those areas actually that the arthroscopic portals can be put through. For instance, here is the entrance of the anterolateral portal, which occurs just before the beginning of the footprint of the iliofemoral ligament. Here's the posterolateral portal, and here's the straight anterior portal. So here are the footprints for the iliofemoral ligament between 12:45 and 3. You can see it there. And then the pubofemoral ligament is from 330 to 530. So it's this segment. So there is certainly from 3 to 330, there's an opening there that the arthropods can put the arthroscopic portal there. The ischiofemoral ligament goes from about 745 to 1030. So you have these two big intervals, superiorly and inferiorly. Inferiorly, the circle, as I mentioned before, is closed by the transverse acetabular ligament. And it's very similar to the morphology of the glenohumeral ligaments and the relationship of them with the glenohumeral capsule, these capsular, iliofemoral, and pubofemoral ligaments. So here we have a coronal T1 FATSAT sequence, and this is from one of our cases. And here's this histology picture from this article, which is pretty much the article in which the entire lecture is based upon, okay? It's an article from Doctors Peterson and Tillman from Kiel University in Germany. And it's about the structure and vascularization of the acetabular labrum with regard to the pathogenesis of and healing of labral lesions. So this is a microscopy light microscopy picture that you can see the hyaline cartilage, okay? You can see a normal developmental cleft that can occur at the transitional zone. And then you have the labrum. And the labrum has like two main components, a superficial and a more deeper component. The superficial is just the straight fibrocartilage, and deeper to that is dense connective tissue. That's what you can see with light microscopy. Okay, so you have this developmental cleft. Here you have the joint capsule. So this is the perilabral recess that we often see. And here on this MR arthrogram, you can see a thin and smoothly marginated cleft superaurally. Here is hyaline cartilage because it has more water content, is brighter than the fibrocartilage that has less water and more connective tissue. And here you have the joint capsule, and this is the perilabral recess, okay? So if we go and see a microscopy, a cross section at this level, superficially, you can see that there are a few chondrocytes that are arranged in a somewhat linear manner. But when you do another cut in the deeper portion where there is the dense connective tissue, you can see that you have fibroblasts, which are larger, more dense, and better orientated than the superficial chondrocytes. So here we have a coronal T1 FATSAT, and this is an axial that I'm going to leave there as a reference with the line. So we're going here from anterior to posterior, and you can see how closely attached the acetabular labrum is to the rim. And as I continue going posteriorly, you can see here very nicely the perilabral recess, okay? And here as we come posteriorly, you can see the sublabral recess that you can see was the same image that I was showing you previously at the transitional zone between the hyaline cartilage and the fibrocartilage, okay? We can have these recesses posterior superiorly and posterior inferiorly, and I'm going to do cross references here so you can see when I put my cursor here, it cross reference exactly here. And this is a well-known posterior inferior sublabral sulcus that was described in the imaging literature. You can see it very often, and it's thin and it's smoothly marginated, and it's in that particular location. When I move my cursor here, then I'm going to the cleft in the transitional zone between the hyaline cartilage and the fibrocartilage, and this cleft sometimes can be problematic. There are very there have been work published about the presence of these clefts on fetuses, and they're not that frequently seen early on in the development. So some people believe that all these clefts are acquired actually. Now, whether they're pathologic or not, that's a different discussion, but there are certainly believers and no believers in the presence of these clefts all being developmental versus you born with some of those, or you just acquire them during life. So this is at the level of the transitional zone. And when I go here, so let me go back this one. It goes to the transitional zone, and this one is the perilabral recess between the capsule and the labrum itself. So we go back to our slide, and those are the structures that you can see. Now this is from that paper, and it pretty much shows you on a somewhat three-dimensional diagram here that the acetabular labrum does have 3 layers, and this is actually the histology of those layers on electron microscopy, and we will discuss a little bit this in depth in a few minutes. But that's just to show you how that planar diagram that I showed you early on, you can make it a 3D, and you can have an understanding of how you have a superficial, a middle, and a deeper layer in the fibrocartilage, okay? And again here, hyaline cartilage. A lot of us are familiar with these slides. This is from Dr. Resnick's talk. And this is great because it shows the work of Dr. Peterson and colleagues at the Department of Anatomy in Christian Albert University in Germany, in Kiel. They did this now classic work where they show the architectural framework of the meniscus in the knee. And again, they show us the superficial layer, the middle layer, and the deepest layer, which is biomechanically the strongest and more important. The same group did the similar work in the glenoid labrum, and they show a similar arrangement of the collagen framework in the shoulder when you compare to the knee. Well, now we have the same here in the hip, but they didn't have a nice diagram like this one's done by that artist during their articles. This was on the hip article. So actually, one of my fellows in previous years, she's very talented. She was like, let me give it a try to see if I can try to reproduce something similar. So this is actually her drawing. Uh, and that you can see the superficial layer, the middle layer, and the deepest layer. And this superficial layer is the one that is formed by very thin fibrils of collagen that they are randomly put in there. They're not that organized, and they're very, very fine and delicate, okay? They do not have any particular orientation. The second layer, from superficial to deep, the fibers are a little bit thicker and they're a little bit better organized. They cross each other at different angles, and they are certainly bigger than the superficial layer, but still they're not that quite organized or that thick or that big. And layer 3, which is always the biomechanically the most important one, well, all those fibrils are organized in a really circumferential fashion. They're circular and they form these thick bundles of collagen, which are the backbone of the labrum. And these collagen bundles actually do continue inferiorly into the transverse acetabular ligament. So I have seen a couple of cases where I have labral tears that appear to extend into the substance of the transverse acetabular ligament, similar to how we see some of the glenoid labral tears extending into the superior or middle glenohumeral ligaments during some of our slab tears. So this is a diagram from StatDX, and it has kind of a coronal and a sagittal perspective, if you will. You can see like the capsule, right? This is the bone, the acetabulum, so it's cut. Femoral head is removed. This is the pulvinar. The fat here is the ligamentum teres, which is a cut, and here it's junction with the inferior transverse ligament. And here in blue, light blue, is the hyaline cartilage. And of course, the hyaline cartilage is a highly stratified structure, which is beyond the scope of this lecture. But superficial to it, or in continuity here, you can see on gray the fibrocartilaginous rim of the acetabular labrum. And you can pretty much imagine your collagen bundles oriented there in a circumferential fashion. So this diagram, if we go planarly, is exactly like that. But as I mentioned, you can go three-dimensionally and have an understanding of how this labrum changes in terms of its collagen framework from superficial to deep. If we go basically, the most basic stuff, and this is something that Dr. Resnick uses for his talk about the meniscus, and you have your labrum being a somewhat triangular shaped structure, and you do pretty crude circular bundles of collagen here, you can use this same analogy to try to locate your tears, whether they are parallel or perpendicular to the collagen bundles, and whether the tears go in between the bundles or actually disrupt the bundles, which biomechanically are the worst ones. Dr. Philippon and colleagues try to classify the acetabular labral tears like in 2 main categories. whether they're due to morphologic abnormalities or functional alterations, or if they are related to trauma or degeneration. And within the morphologic alterations, there are two main groups: the fermoacetabular impingement group and the dysplasia. And I will show you cases of labral tears on patients with CAM and pincer and mixed type FAI, as well as tears in dysplastic hips. Functional alterations, the instability group, which is something that is gaining more recognition during the last 5 to 10 years, the concept of microinstability in the hip and the role of different ligaments, including the ligamentum teres and the capsular ligaments, as well as the role of the labrum itself. So when you have hip instability, you can have certainly labral tears, as well as patients with iliopsoas impingement. And the traumatic and degenerative tears speak for themselves. So there were, for a lot of years, there were two main classification of labral tears. There was an arthroscopic classification that it was published by Dr. Lange on the Journal of Arthroscopy several years ago. And then there was a classification on imaging, actually on MR arthrography, published by Dr. Cerny and colleagues on the Yellow Journal on AJR. So here you have actually the original article where Dr. Lange described the acetabular labral tears, and this was an arthroscopy in 1996. And you can see already a similarity in the terminology, and it's similar to the terminology that we use to describe some of our tears in the shoulder and in the knee. We talk about longitudinal peripheral tears, we talk about radial tears, we talk about fibrillation, and this was, of course, an arthroscopic classification. Dr. Cerny published his work on AJR in 1999, and he came with this classification of 3 stages, whether you is a stage 1, 2, or 3, type A or B. Kind of a very thorough classification, but to tell you the truth, I haven't used this classification, and there are articles that have shown that the correlation of this particular classification with the Lange arthroscopic classification is not that great. Actually, the group from Dr. Blankenbaker out of Madison published in the Blue Journal on our journal in Skeletal Radiology in 2007, an article about the classification and localization of acetabular labral tears, and the conclusion of the article it does say that Cerny MR arthrographic classification or a modification of an MR or that classification does not correlate very well with the Lange arthroscopic classification. So what Dr. Blankenbaker and Arthur Desmond and colleagues proposed at the time is to use the clock phase description to try to localize these tears more accurately when we get the study and before the patient goes to scope. So that's pretty much what we do, or what I do, which is superimposed clock phase. And it's not a straight vertical, it's a tilted clock phase along the long axis of the bone, with 3 o'clock always being anterior, the same as we will do in the shoulder. This does can pose a conundrum there with the orthopods, because the orthopedic surgeon, they read the labrum in the hip or the labrum in the shoulder the same way as we will read the breast on breast imaging. They will flip the clock phase, whether it's right or left. As by definition, 3 o'clock is always anterior on MR imaging. So I do a combination of both. I use the clock phase and I use quadrant anatomy, and sometimes I'm redundant on my descriptions, but it's just to be sure that the orthopedic surgeon understands that when I'm referring to a particular tear in a specific location, in which quadrant it is and from which position and which position in the clock phase. Subsequently, because there was lack of correlation between these classification systems, a group of researchers, orthopedic surgeons, come together and form this Mayhorn group, which is a multi-center arthroscopy of the hip outcomes research network. And they got together and they proposed this more simple way to approach these labral injuries. And what they tell us is that we should look at the size of the labrum. If it's normal, if it's big, or if it's too small. And then we should look at the tear. If it's a partial tear or a complete tear, like a labral separation, and if there's a flap or not, or if it's a complex multidirectional kind of tear. And then if you can mention about any intersubstance changes. Sometimes you can have mucoid changes, particularly on these degenerated labra in these plastic hips, or you can have mineralization of the acetabular labrum or ossification actually sometimes. So that's what they propose. And this was actually the article where that classification was proposed, the Mayhern classification system. And again, they go size, and they describe the tear as partial, as complete, if there is a complete controllable separation, if there is any flaps, and then if there are any changes. A lot of this is arthroscopically, but we try to, or some groups have tried to adapt this to MRI. This is actually from Dr. Schmanzer. He is probably with Dr. Cersol from Spain. These are the two main groups that use MR arthroscopy of the hip with MR arthrography of the hip with traction, okay? So Dr. Schmanzer actually modified this Mayhern criteria and proposed this classification, not only for the description of the labral injuries, but also for the description of the lesions in the hyaline cartilage, which I'm not going to talk, that's beyond the scope of this lecture. So here's what it is. So I superimposed a clock face on a tilted clock, and I ended up having my quadrants, and inferiorly and near in the 6 o'clock position, that's where the inferior transverse acetabular ligament is. Dr. Elizalituri, he's from Mexico. He together with, this is who's who in the world of hip arthroscopy. I mean, you have Dr. Burr, Philippon, Dr. Mardon, Dr. Wanchi, they come together and they describe this particular method for the localization of labral and cartilage injuries in the hip. And what they did was that they separated, or they put 6 zones on the acetabulum that match perfectly with the same 6 zones in the femoral head. And the same 6 zones on the right side are the same as on the left side. So a lot of practices may use this Elizalituri classification system for location of lesions. And actually a couple of the hip surgeons in my institution do use this classification in their arthroscopic reports. So certainly when I read cases from them, I use the same classification for the description and location of the labral and chondral injuries that I may see on the hip MRI studies from their patients. This is what they did. These are pictures from their article. And certainly zones 2, 3, and 4 is where more frequently we'll see the 95% of the tears in our population, and they do match the same areas in the femoral heads, and it doesn't matter if it's right or left. And this is borrowed from one of Dr. Chang, Christine Chang's articles about the labrum on AJR, where she superimposed that nice tilted clock face along the glenoid. We use the quadrant anatomy, and you end up having your 4 quadrants on 12 to 3, 3 to 6, 6 to 9, and 9 to 12. And I do the same for the hip. And that's how we try to describe that. Now, from the arthroscopy side, there is this nice paper from Dr. Philippon and Bob Laprat. This was a research study done at the Stedman Philippon Research Institute in Vail, Colorado, that they did these nice diagrams as usual from their group, showing us some of the bony landmarks that they will use for orientation of the scope. And certainly they use the stellate crease, which is near the 12 o'clock position, and they use the indentation from the psoas. There's a little anterior recess here, what they call the psoas U, for the 3 o'clock position. And here you have the footprints for some of the muscles and ligaments about the hip. Here is more anatomically. Here is just clock face center, but this is how it is tilted. So the 12 o'clock is very close to the stellate crease, which is between 12:30 and 1, and the 3 o'clock, the 3 to 9 axis is just above the top of the psoas sulcus at the 3 o'clock position anteriorly. And as we mentioned before, inferiorly we have the transverse acetabular ligament. And this is This is a picture from their article, so you can see here the region of the stellate crease, and here you can see the indentation of the sod. So this is about anterior and 3 o'clock, and this is superior and 12. So that's how they do orient themselves when they're looking at the hip from inside. So those are our 4 main diagrams, and we're going to try to use this one to show the different kind of labral tears that I'm going to show you before. These are 2 examples that Dr. Sersol uh, very very nicely loaned me for this lecture. And I just want to show you guys this because you're going to see the difference between the images that I'm going to show and this. This is with traction, and you can see the space that you get here, and you can see how beautifully you can depict some labral tears, particularly for contralabral injuries. This is a coronal T1 MR orthographic image without that much traction, and you can see it here with traction. I mean, you can see a labral tear, but the area of basilar chondral delamination here, you can certainly see it better with traction. So thank you to Luis for his generosity sharing that couple of examples. And these are, or this is at least what I deal with on a daily basis. This is an arthrogram, as we were discussing with Dr. Gutierrez and Dr. Singer just before the lecture. Even if you put 12 or 13 cc's of contrast, the contrast will go to the recesses, and we usually don't get that much of a distension in the wavering portion, the superior aspect of the femoroacetabular joint. So here's our routine MR arthrogram protocol with a T2 and a T1 fat sat, a T1 non-fat sat, a sagittal, axial, and the axial oblique. So here, what I'm showing you is the first group of tears, which are the so-called longitudinal tears. Those longitudinal tears is because they are parallel to the longitudinal axis of the joint and the orientation of the bundles, and they can be certainly longitudinal, similar to the meniscus in the knee. They can be longitudinal vertical, or they can be longitudinal horizontal. Sometimes they can be longitudinal oblique. Okay, so here, if you see already, you can see on the sagittal, axial, and axial oblique images, you can see that this is a tear that does extend from anterior to posterior. That's an AP fashion that you can see in the 3 orthogonal planes. And when you scroll on your coronal images, you can certainly see already reactive matter change there, and you can see the tear extending to propagate there. And as you keep on going from anterior to posterior, you can see the tear, which is somewhat horizontal, then oblique, and then more vertical. And that was a longitudinal tear on the periphery of the meniscus that it was easily seen by the arthroscopist on the periphery of the supralateral portion of the acetabular labrum. Here is a different case, almost similar like an Oreo, like a double Oreo sign here. You can see that there is another vertical tear near the base of the acetabulum. You see that the tear extends in an AP fashion, and as you keep on scrolling on your coronal images, you keep seeing that tear, and there's a perilabral recess there, and you do have this plastic bump here at the anterolateral aspect of the femoral head neck junction with some associated fibrocystic changes on a patient and an increased alpha angle on a patient with a clinical diagnosis of CAM type femoroacetabular impingement and an anterosuperolateral longitudinal labral tear. This one is also longitudinal. It goes from AP, but is more horizontally oriented, not as vertical as the other, and in between the bundles. So here you can see on the sagittal plane, on the axial, but not on the coronal like on the other ones. You can see as I scroll, this is a T1 fat sat and a T2 fat sat. You can see the horizontal orientation of this tear that keeps on going and going, paralleling the axis of the labrum, okay? And not infrequently, you can have these tears that are associated with areas of chondral delamination, and then they keep on propagating into the fibrocartilage of the labrum itself. So that's more of a horizontal tear. Here you have another example, this one with a large area of basilar chondral delamination, and you can see that it has this horizontal orientation in 3 orthogonal planes. And here, when I cross-correlate in the hyaline cartilage, you can see that that area of basilar delamination was extending actually towards the base of the labrum through the transitional zone. And there you see it, and there you have it. So that was Nate with the Dr. Andrews with the scope, showing me the horizontal nature of this tear, different to the previous one, which was more oblique or vertical, if you will. That's different to this type of tears. This is, if you see, is not those longitudinal tears. This is a tear that is kind of perpendicular to the axis of the acetabular labrum, and you don't see these tears going on and on several sequences, on several slices, depending on the length of the tear. These are more focal tears, and these tears are radial in nature. They're perpendicular to the orientation of the collagen bundles or the circumferential fibers of the labrum. They can occur towards the free edge. They can occur in the mid-substance. Sometimes they can occur near the base. They can completely, when they're occurring here in the tip, you can see sometimes a blunted, quite blunted, almost like surgical looking labrum. But in my experience, the majority of them are more towards the substance and base, or the ones that I have seen. Certainly here you have another one. This one is on the sagittal plane, coronal. On the coronal orthogonal plane is only on one image, as well as on the axial. And here was Dr. Andres putting that tear that he was running in this direction instead of the other ones that I just showed you. When you have the tears, they can be partial, they can be complete, and sometimes they will detach all from the chondrolabral junction and all from the labral osseous junction. So you have a complete separation of these tear occurs here, and you may end up having the labrum like floating like that. So here you have a case, an example. You have the tear here in the base, and as I keep on going from anterior to from medial to lateral, you can see, sorry, you can see that the labrum, it's completely detached, and here was the corresponding arthroscopic picture. Another feature that I wanted to discuss quickly, the presence of paralabral cysts. They can be small. They're usually a secondary sign of a labral tear. If I see one and I don't see a labral tear, I go back and pay close attention, because not infrequently there will be a very subtle one. Here you have a type 1 supraacetabular fossa. The paralabral paracetabular cysts sometimes can be adjacent to the tear. Sometimes they can wander away from the tear. They can even be on the other side of the bone, and they can be big. So it's important to know those. Sometimes you can see a little bit of gas. Sometimes you can see crystals in there. They can be complex. This is a case of perilabral with intralabral and intraligamentous cyst formation, okay? You can already see, this is an arthrogram, you can already see on the T2 and the T1s that there is a complex tear with multidirectional elements here. You have vertical and you have horizontal components. This one kind of a cleavage type of tear exiting through the apex of the labrum. And as I scroll on the sagittal plane, I want you to pay attention to this structure. This is fluid on the T2 that is dark on the T1. So it's no gadolinium, it's native fluid. And this was interesting because I have seen something like this in the shoulder. And it's like, if I go back and forth here, look at the extent of this labral tear on the sagittal plane. These are zones 2, 3, and 4 of Ilisari Turi. So it's anterior superior, mid, and posterior superior labrum. And you can see the extent of that labral and chondrolabral abnormality. It goes all the way. And as I keep on going anterior superiorly after the 2 o'clock position and to the 3 o'clock and even inferiorly, you still see abnormality. And then I get to this image. And this image is the inverted horseshoe, and this is the inferior transverse acetabular ligament that completes the circle. And as you can see, what we were seeing here was actually cystic intrasubstance cystic formation. Is no gut, is fluid within the substance of the transverse acetabular ligament that is almost in continuity with that quite extensive acetabular labral tear. And I have seen a phenomenon similar to this in the shoulder when you have your glenoid labral tear and you have tear or cyst or contrast penetrating into the substance of the glenohumeral ligaments. And you can certainly have seen cystic degeneration of cruciate ligaments and so in other in the knee, as well as in other ligaments and tendons in the body. So I think in this particular case, I haven't seen this too often in the hip, but that's one that I wanted to show you on this case with intrasubstance, perilabral, and intralabral cyst formation, as well as intrasubstance cyst formation here across the transverse acetabular ligament. Chondrolabral lesions, I'm not going to talk too much about it because it's beyond the scope of the talk, but just to remember that similar to the GLAD lesion, which is GLAD, the shoulder, for glenoid labral articular disruption, we have an ALAD lesion, or acetabulolabral articular disruption. And these are injuries that can occur at the chondrolabral junction. Case in point here, you already have subchondral cysts with reactive marrow change in the supralateral aspect of the acetabulum, and you can see the fissure with the area of basilar chondral delamination in the underneath cartilage on a patient with an ALAD lesion. And there's a classification system for ALADs that is also has also been proposed. Here was the arthroscopies showing how these chondrolabral delaminating injuries are kind of carpet-like when they probe them. It's like when you unroll a carpet, they can roll that way. You can see here on these two images courtesy of Dr. Andrews. Here we have another case of a complex labral tear. And this one, as I go on the sagittal plane, you can see that it has vertical and horizontal components. It's almost through and through. There is a tiny cyst associated with it. And then as I keep on scrolling more anteriorly, I see this well-corticated, fat-containing ossicle, which is a large os acetabuli on a patient that also has a bump, some morphologic features of mixed type femoroacetabular impingement with pincer and cam type features. Here you can see nicely the location of the ossicle in the different orthogonal planes. And that was the arthroscopy picture showing the ossicle, which was resected and the labrum was debrided. The last two groups will be the dysplastic hips and the post-traumatic tears. So the tears that occur, the acetabular labral tears that occur on dysplastic hips are usually quite complex in nature. So here, let me show you, this is a coronal T1 non-fat SAT and a fat SAT, and here we have a sagittal just for cross-reference. So look at the size of this labrum. The hip is clearly dysplastic on both sides of the femoral head as well as in the acetabulum. And you have this compensatory hypertrophy of this labrum, which is very swollen and degenerated with altered intrasubstance signal. So that's the corresponding radiographs for that particular type of labrum. Here, you can see that it was bilateral, but certainly left more than right dysplastic changes. Here we have a different patient. This was a 44-year-old female with a hip pain and a dysplastic hip. And you can see that the labrum is quite abnormal. This is a big labrum with intrasubstance altered signal. But as we scroll, we can see that the labrum, in addition, is detached from the osseous rim, at least partially detached. And then as we come here more anteriorly, you can see that there is this large multilobulated and complex paralabral or paracetabular cyst, if you will, that is actually creating chronic appearing remodeling and like erosive-like change on the iliac bone in the lateral cortex on its supraacetabular region. So that was an interesting feature. There was synovitis within this cyst, and you can see that on the fluoro image, you can see the dysplastic features of the hip and the acetabulum, and you can see the remodeling changes in the lateral cortex of the supraacetabular region related to the presence of that quite large paralabral tear on a patient with an extensive degenerated hypertrophic labrum on a background of a dysplastic hip. This is the other example that I have for dysplastic hips. This one is already quite abnormal. As I scroll, you can appreciate that there is evidence of coxa plana, coxa magna, and breva. There's also coxa valga, and all these certainly is the sequela from Calvi-Perthes disease. This was a 16-year-old kiddo that you can see has extensive complex tearing of the acetabular labrum and sequela from LCP with associated arthrosis, cartilage loss. And here you have the X-ray showing all the features of left calviparathes on X-rays and the unilateral involvement. Traumatic tears, usually we see them here in our population after trauma, MVCs, or sports injuries. There's a nice article on the American Journal of Sports Medicine from the HSS group with Holly Spotter about the MR imaging appearance of these post-traumatic labral tears, posterior labral tears in NFL players. I have a couple of examples here. One of them is actually from one of our football players from the UVM team that got tackled from the front and the hip dislocated posteriorly. So here you can see already the fracture of the posterior lip of the acetabulum. You can see the labral tear. And as I come anteriorly, here you can see that there is a little paralabral cyst anterosuperiorly near the 2 o'clock or at the 2 o'clock position with an associated labral tear, so an anterosuperior labral tear with a paralabral cyst and a posterior labral tear with a fracture of the posterior acetabular rim. You have your cyst there, nicely demonstrated. So that's that particular case of a posterior hip dislocation with a posterior labral tear and an associated fracture. That was the proposed mechanism of injury. Remember always the circle concept. If you have an injury on one side of the circle, go and look on the other side, as we have primary and secondary restraints to these translational events that can give you counterclock injuries not infrequently. Here's another patient, this one with a nice lipohemarthrosis, the CT of the abdomen and pelvis at the time of the injury. I think this was an MVC, if I remember correctly. The hip was still dislocated. And then we don't do MR imaging on these cases, but these are actually axial T2 non-fat sequences from an MR venogram, a pelvic venogram that they ordered on this patient. And you can see I just stole this image from the MR venogram to show the posterior labral tear after the successful and concentric reduction of that left femoral head within the acetabular fossa. And these are drawings from that article, excuse me, it wasn't an American Journal of Sports Medicine, it was on JBJS from 2003 about the posterior hip traumatic dislocations on NFL players and the association of the posterior labral tears, posterior posterior wall fractures, as well as injuries of the capsular ligaments, particularly here the iliofemoral ligament of Bigelow near its distal insertion, trochanteric insertion. This is another case of a hip dislocation. This was the kid that the football player from UVM. I like this picture because it's similar to Hillsex's and a Bankart. You have the impaction injury. This was not the the fovea capitis of the ligamentum teres that was above. This was an impaction injury when the femoral head knocked off this piece of bone from the posterior acetabular rim. And then we found this little small piece of bone here, and this was an avulsion fracture actually from the ligamentum teres. And this was the MR to show the posterior wall and labral tear, the fracture, and here you have your avulsed piece of bone from the footprint of the ligamentum teres at the fovea capitis. And this is courtesy of Luis Sersol, this diagram from Max Crespi that shows the phenomenon that occurred in this particular case. And lastly, let's see, we have 5 minutes. I just put here at the end a couple of cases about the post-operative imaging, the imaging of the post-operative acetabular labrum. So here, coronals and sagittals. And just to show you, this was a patient with a labral repair. You can see here one of the anchors, 2 of them, and you can see that the area of the repair is pretty good. It's pretty well sealed, very closely opposed. There is no penetration or undermining or imbibition of contrast, no paralabral or paracetabular cyst, and no residual signal within the labrum itself. So this repair was looking pretty good. The philosophy here is the same as the labrum in the shoulder and the meniscus in the knee. The surgeons are trying to preserve as much as possible, depending on the complexity and location of the tear. If it's, excuse me, if it's in the avascular zone, or if it's more towards the periphery, that you have more of a red zone, more vascularity, and if it's repairable, and the quality of the cartilage, of course, is also important to keep in mind. So that's that case. This is another one that was a little bit more difficult to interpret it because there was susceptibility artifact and maybe some air from the arthrogram. But here you have the tracks from the repair. There was no penetration of contrast here anteriorly. I wasn't too sure, but I ended up calling this negative, and the patient did not went back to the arthroscopic table for surgery. This one was a repair, and this was a subsequent, a type 2, I suppose, or 1 supraacetabular fossa. And here you can see the labrum. There's some reactive marrow change, but you can see here the appearance of this post-operative labrum. This was repaired with sutures, not that much of debridement, and you can see that there is penetration of contrast, abnormal morphology. This one, I wasn't so sure, so I suggested that this was a re-tear with an additional tear here towards the base and an area of basilar corneal delamination. And this patient went back to the arthroscopic table, and they ended up debriding the labrum because it was felt to be torn. So they debrided the portion of the anterosupralateral labrum. This was between 2 and 3 o'clock positions, and then they did some drilling of a corneal lesion that it was on the acetabular side. So that was this case. I just wanted to show you a couple of examples of normal and one abnormal, at least that I know of post-operative labrum with repair. So in summary, the architectural framework of collagen in the labrum of the hip is very similar to the glenal labrum in the shoulder and the meniscus in the knee. That's why the pathology that we encounter in these 3 structures is similar in terms of the imaging appearance, the pattern of failure, and the way of propagation, always following the path of least resistance. For you to have these tears that break through and through the collagen bundles, the circumferential collagen bundles, you need a lot of kinetic force. Is different than a degenerative type of tear, you know. So this is the 3 diagrams from one of a previous fellow, the knee, the shoulder, the hip, showing us the similarities in terms of the superficial, middle, and the biomechanically more important deep layer. I think that MR imaging together with the histology has helped us to better understand how this labral tear occurs, how do they fail, and how they propagate the way they do. And I think that a suggested approach for these acetabular labral lesions is to try to localize the lesion as accurately as you can, whether you use the quadrant method or the clock face method or the Ilisalituri method. Just be sure that you talk to your orthopedic surgeons so we are all speaking the same language. Try to determine the type of lesion if you can, a labral tear versus a partial or complete, or in other words, a tear versus a detachment. Try to characterize the lesion if possible. Sometimes we cannot, but sometimes you can see if the tear is more longitudinal or if it's radial or if it's complex or if it's complete and fully detached or if there is the presence of a flap, though that's important information for the orthopedic surgeon. Try to identify the conditions that may be predisposed to that labral pathology, whether it's DJD or if it's a dysplastic hip, or if there are morphologic features of FAI, or if it was a post-traumatic tear. All that information is certainly useful. And special attention should always be paid to associated chondral lesions. The articular cartilage is always the innocent bystander, so that's always a good structure to look at when you have pathology on the labrum. Look at the cartilage. When you have pathology in the cartilage, look at the labrum and for other secondary signs. With that, I think it's the end. These are my references, and I want to thank you all for your attention.
Thank you so much, Diego. We did have a couple of questions rolling, so if you have time, there are 3 of them.
Sure.
The first one is, what are the main characteristics of a labral tear you feel you must mention in a report?
Correct. So I think that it's important to mention if the tear is partial or complete. In other words, if it goes through and through, if it's displaced or not, and if there is a flap or not. Those are things that after talking to several of the hip surgeons, that's what they care a lot. Of course, they care about the accurate location of the lesion, but if we can tell them if the thing is partial or if it's complete, if it's completely detached, and if there is a flap, they will certainly appreciate that.
Got it. The second question is, in what plane do you measure labral tears of the hip?
So I try to, it depends of the type of tear. If it's a longitudinal tear, I try to measure it in the axial oblique or on the sagittal plane. That's when I get the best look at it, as I show in a couple of my examples. Radial tears are more difficult to measure because you are going through the short axis of the labrum. So I don't measure radial tears. I measure if they are partial or if they are complete and displaced. But other than that, I just cross-correlate the tear in the best plane that I see the tear itself, and then I look on the other 2 or 3 orthogonal planes to see which one gives me the tear in its entire length, and I try to give them a measurement about that. If you know the length of the tear and your protocol in terms of the slice thickness, you can give them a pretty good idea if the tear is larger than 10 millimeters or not, in terms of instability and complexity.
Okay, and that brings to the third question. So do you differentiate stable and unstable tears, and if so, how?
So I don't, but when I describe the tears, I use descriptors that the orthopedic surgeons associate with instability. And some of those descriptors have to do with the complexity of the tear. Complex tears with multidirectional elements in their view can be unstable when compared with a more simple appearing labral tear. The length, when I can measure it, if it's more than 10 millimeters, similar to the meniscus in the knee, they will pay attention to that. Or in other words, if it extends over 2 of the salutary zones, that's over there is about 10 millimeters or so. So they do care a little bit about size, extent, and complexity of the tear to determine the instability. Certainly, if it's a through and through controllable separation, that by definition is unstable.
Thank you. And I had one additional question for you. At your institution, do your surgeons ever discuss whether or not during the time of an arthrogram injection of local anesthetic is helpful in terms of helping to characterize whether the pain is actually generated from a labral tear that you diagnose or not?
Yeah, occasionally we have, one of the surgeons occasionally requests his arthrograms to put a local anesthetic to do a pain scale stratification before and after the arthrogram to see if it was intraarticular etiology. What we see more often now is actually before we do the MR arthrogram, they request several ultrasound guided injections. If they think that it's extraarticular, they may request a trochanteric bursal injection or an ischial injection or an iliopsoas injection. And if nothing of that works and still the clinical picture is confusing, they may request a fluoro-guided intraarticular injection. But to do the local anesthetic, the ropivacaine, at the same time with the arthrogram is not what we do all the time. But I have talked to other MSK guys in different institutions, and in some places they do it always, and they provide that information in terms of the pain scale before and after the study. They add that in their report. So I think that it can go either way. I mean, in our institution, we have one of the surgeons doesn't want to do any more arthrograms. He just wants to do routine high resolution MR images on the 3D magnets for his hips. And the only instances when he's requesting us to do arthrograms is in his post-operative labra. Or patients after, camplasty or acetabuloplasty with FAI and labral debridement or labral repairs. In those cases, he will put the contrast. He will request an MR arthrogram. Other than that, he just prefers. He's happy with the way that we are optimizing the 3T protocols, but that's just him. The majority of the other surgeons, they still prefer MR arthrography over routine. And that's, different. It changes from place to places. I mean, as you know, in the Northeast, in HSS, at the Hospital of Special Surgery, they They don't do any arthrograms at all. They have great sensitivities and specificities, diagnosing all these labral tears in the shoulder, in the hip, TFC tears, with the work of Dr. Holly Spotter and colleagues. So I think it changes from place to place. You just have to educate your eye and set up your thresholds for the things that you're going to call. But at the end of the day, the arthroscopic surgeons own the patients, and they request the study that they feel more comfortable with also looking at. So we still see the majority of our docs requesting MR arthrography in these instances.
Thank you, Diego. Really appreciate your time, and thanks for coming and talking today. We'll have the next lecture coming up in the next couple months with the shoulder, so we're really looking forward to that.
Thank you, thank you.
So with that, we'll conclude today and tune in next week for the next lecture in the e-lecture series.
And if there are questions that we didn't have the chance to review, they can send me an email at the beginning of my lecture. Is the email, so I'll be more than happy to answer other questions if there are.
Do you have your email up there that you can?
Yes. Let me just go here to the beginning, and I leave it there so people may just copy it.
There you go. So if you want to just pause that when you're watching the video, it'll be uploaded later this week, and you can get Dr. Lemos's email there and email any additional questions. All right, everyone. Thank you so much. Stay safe, and we'll see you next time.
Thank you. Bye-bye.